Hello, my name is Kristina Glubcheva, and I would like to share with you my recent insights about ocular surface in aniridia. And here I would like to point out that there is a very nice concept about visual, perceptual, and cosmetic discomfort. And this is very important when we are talking about patients with aniridia. But I will come back to this during my presentation. So what is ocular surface? The normal ocular surface consists of several components, and that of course includes the cornea, the transparent front bit. Also, it includes the conjunctiva, and conjunctiva is a very complicated structure. It's actually like a sac that starts from the palpebral margin and goes down to the limbus. And conjunctiva may be a reason for very, very significant perceptual and also cosmetic discomfort. However, we should not ever forget about the lids because the lids are playing very significant role in ocular surface maintenance and they're very important for the clear vision as well. And last but not least, part of the ocular surface is the tear film, and the tear film components may be very significantly changed due to variety of ocular surface disease. So, talking about anterior segment, we should not forget about the limbus. Limbus is the shed area, the border between the sclera and the cornea, and it is also covered with the conjunctiva. Inside there, we have a very special cells called limbal stem cells. Those cells are important because they are responsible for fast regeneration of the ocular surface. And when we have problems with the limbus, usually we have either inactive or absent limbal stem cells, and this could be a significant problem. Another very important thing is to highlight that lids are walking through the anterior ocular surface all the time. So basically, it is interesting to know that lids are making up to 40 kilometers a year. So this is very important, lids to have normal structure, but also ocular surface to have normal structure, because otherwise we are observing changes like highlighted here called lid wiper epithelopathy, which basically means that not only the lids can injure the cornea and ocular surface can also injure the lids. And this may lead to very significant vicious circle. So coming back to the idea about comfort, in order to have eye comfort, we need to have three levels of comforts. The first one is, of course, the visual comfort. One of the main functions of the eye, of course, is vision. And in order to have good vision, we need to have transparent optical media. And if we have tear film disturbances or corneal disturbances, we definitely have problems with visual comfort. And this visual comfort may be associated with a variety of different symptoms, but most of them are associated with micro aberrations. Another important point is so-called perceptual comfort. How do I feel my eyes? And lots of patients with ocular surface disease would complain that they feel grittiness, they feel sand into their eyes, they feel their eyes burning, they feel their eyes itching, they want to scratch their eyes. Last but not least, every patient would like their eyes to be bright. And red eye is actually a significant symptom of discomfort. So red eye can reflect into the so-called cosmetic discomfort. So let's come and look at aniridia. This is actually one of my patients, and she does not look like an iridic patient simply because she had cataracts, bilateral cataracts, and she has Morter lenses implanted into the eye. So she has no artificial iris, she just has Morter lenses. So what about the cornea of this patient? Well, most of our patients with aniridia are having corneal problems. And those corneal problems are proven to be secondary to the limbal stem cell deficiency. And this is up to 90% of our patients. So knowing what is going on at the limbus, and with contemporary confocal microscopy we actually can do, is very important for our aniridia patients. Also, those patients are usually having increased central corneal thickness as a result of recurrent edema and as a result of ongoing fibrotic process. They may also have vascularization, which closes the vicious circle, subepithelial fibrosis, and as a result of this, the corneal transparency is missing, so cornea started to be opacified. Interestingly, the cornea, when there is no patent limbal stem cells, gets a process called conjunctivalization. And this is in vivo confocal microscopy, which basically demonstrates goblet cells here into the cornea, and they are part of the conjunctiva. So in those patients, we definitely have more risk for development of ocular surface disease. And finally, the cornea starts to change its surface, it may ulcerate, and therefore we may have ulcers with acute or chronic inflammation. And this is some in vivo confocal microscopy reveals. As you can see, the palisades and the limbal stem cells are very tiny. So basically the palisades are looking more like little threads than real massive palisades. We have also absence of subbasal epithelial nerves. We have very destructured subbasal layers, and also we have a reduction of the basal epithelial cells, like shown here. When we are talking about limbal stem cell deficiency, I would like to remind you a relatively old but very, very good classification made by Lopez Garcia. And basically, this classification divides an aniridia-associated keratopathy with three different phases. So the first one is slight limbal insufficiency. So the patient usually has normal or a little bit red eye from time to time, and they have occasional recurrent erosions, like up to 2 erosions over 6 months, and they're usually with very small panels. The second stage is moderate, and they have more frequent corneal erosions and permanent instability, red eye, and constant epiphora, and photophobia is much more significant, although it can be seen in the first stage as well. And then the third one is severe limbal insufficiency, when we really have corneal ulceration, constant loss of vision, and those patients really need to be treated on time, because otherwise they may permanently lose their vision. And this is what you see here, like stage 1, stage 2 with redness, already a little bit of change in the limbus with a little bit of pannus, and stage 3 where we have already Labrador keratopathy, so this is elastoid degeneration as a result of this chronic inflammation. So how we can assess patients with aniridia? Well, basically we have lots of instruments in ophthalmology that we can use, but not all of them are very applicable. The first one I would like to start with is questionnaires. Yes, questionnaires are a very nice way to assess symptoms of our patients and symptomatic presentations of a disease. However, when we are talking about patients with aniridia and questionnaires, they could be very challenging for them, because some of them are having very low vision, quite significant nystagmus. So currently, we are trying to work a way to utilize questionnaires for patients with aniridia. The second thing is the clinical examination. Clinical examination includes biomicroscopy. Basically, I cannot imagine ophthalmology examination without biomicroscopy, but this can cause photophobia and sometimes is very difficult. And I already mentioned that in vivo confocal microscopy is an extremely good tool. However, it has very bright lights, and most of patients with aniridia are having significant discomfort when they need to have in vivo confocal microscopy. Last but not least, I would like to point out that testing visual acuity may not be standard in patients with aniridia because we need to select proper charts, proper type of charts. We need to pay attention to the lightening conditions. They should be constant, by the way, in order to have a relatively good outcome for repeatability of our results. And sometimes because of nystagmus, we need to break our general rules and test visual acuity binocularly. So what about the visual comfort in aniridia? I would like to go back to my patient, and she's actually a law student. I operated her many years ago, like maybe 5 to 6 years. Her binocular visual acuity is 40%, but her self-assessment for visual comfort is very good because she can do everything she wants. She has very little photophobia. She feels independent, and she has very little visual fluctuation, and when she has them, she actually can apply artificial tears and they help her. What about perceptual comfort? I would like to show you a second patient of mine, again with aniridia, and he complains constant irritation. He has high IOP, therefore he has anti-glaucoma drops, 2 bottles of them. And most of the time he cannot open his eyes, although he has only one partially seeing eye, which is this eye that you see on the picture. He is dependent on his relatives, and his assessment for perceptual comfort is bad to very bad. So it took me quite a while until I took a decision to make a combined surgery for him and actually make corneal graft with implantation of a Murcher lens. But this improved not only his visual but also his perceptual comfort on a long run. And finally, talking about cosmetic comfort in these patients, you may say that those patients are not bothered by red eyes. Actually, it's not the case because some of them are seeing their red eyes in the mirror. Some of them are having feedback from relatives or peers or people via social contacts. And this really bothers them. So having a bright white eye is important for those patients as well. So another issue is this one, and I'm not pointing this one because I like the condition. I'm pointing this one because actually most of my patients with aniridia are suffering also Demodex. And this is relatively easy to treat disease. However, the problem is that we need to treat it with solutions that are having tea tree oil. And this is quite irritative for patients with aniridia. So we need to be really careful in diagnosing, treating, and most importantly, prevent the condition, because this condition may cause trouble for patients with aniridia. So what are the hopes and perspectives for patients with aniridia? We know that aniridia is a rare disease, and therefore, because it's a rare disease, we do not have lots of those patients in our clinics. But every month I have 2, sometimes maybe 3, depending on how they feel, and we need to give them all the perspectives that can help them for the future. So the first thing is ocular lubricants. I would like to point out that not every lubricant is good for our patients with aniridia. And hyaluronic acid is actually subjectively and objectively proven to have better effect on the ocular surface. And this is hyaluronic acid versus carboxymethylcellulose, and this is hyaluronic acid versus HPMC. So in my opinion, when we prescribe artificial tears for patients with aniridia, we definitely should rely on hyaluronic acid. It's more natural, it stays longer on the ocular surface, it gives better comfort in those patients as well, and it is proven to be really superior against any other agents. Biological therapy, however, gets more and more popular. And one very important biological therapy is serum drops. Either put in those small bottles or put in small vials or put in variety of different means that we can use in different countries. Autologous serum is one of the biological treatments that we apply more and more in patients with aniridia. Also, we can use allogenic serum. However, this probably is not a very good idea, and I'm going to show you why. And we can use variety of different preparations. So one of the best advantages of serum drops is that you can prepare them and you can basically use the biochemical components of the own blood of the patient. However, even in 2017, which is now already 5 years ago, we had some doubts that pure serum drops are having very significant beneficial effect on the ocular surface. And this is publication that was based on systematic review, based on 95 different published works. So today we are more talking about plasma-rich of ingrowth factors. This rich plasma is not very difficult to prepare, but actually it has proven effect on epithelial cell regeneration, their proliferation and migration also on the ocular surface, and also it provides better healing, and this is proven by ex vivo confocal microscopy. And as I mentioned, it is nothing difficult. You just need to use the proper vial in order to prepare it. And after that, importantly, it does not need to be diluted. Another exciting therapy that I would like to highlight is cultivated limboepithelial stem cells. And what we do, we actually use denuded amniotic membrane. We take the cells from the amniotic membrane and we use this amniotic membrane as scaffold on which we grow limboepithelial cells. And we have a special mediators in order to achieve this here. So in order to have regular epithelial cells all over the entire membrane. And this is a short video just showing what we do. So basically this unstable ocular surface we deepitalize. After that we are using this custom-made ring which is quite loose, and this is on purpose. And then without touching the cells we fix the ring with interrupted sutures, and after that we just put a contact lens over it. And this simple operation is not very difficult to be performed even by a resident. The problem is that this operation requires lots of preparation. And I must say that our initial results are extremely good, and we actually managed to transplant 5 patients with aniridia with 6 limboepithelial amnion transplants. And on the OCT picture here, you see one of our patients. Basically, very fast, in 20 days, we managed to achieve much better corneal thickness and much better regeneration with this biological therapy. So in conclusion, I would today go for plasma-rich growth factor, and this is an excellent solution for ocular surface disease for all patients with aniridia. I would probably go for any drops that are based on hyaluronic acid, but I would also highlight that non-preservative drops are the most important one. And transplantation of the limboepithelial cells cultured on amniotic membrane shows very, very good initial results. We can also use amniotic membrane per se without cells, but the effect is definitely slower and not so pronounced like in this already custom prepared biological product. And finally, I would like to highlight that corneal transplantation is still a very challenging procedure in patients with aniridia, and we have quite a lot of trouble with this. And I hope that we will be able to make a cornea made in laboratory one day from our own stem cells. And then I hope that we have less rejection and better optical comfort and perceptual results. So, yes, there is exciting hope and there are lots of perspectives. And I hope that all the scientists all over the world will be able very soon to give us more solutions. And we can apply those to all patients with ocular surface disease. And of course, those will be applied to patients with aniridia. Because it is not easy to live with aniridia, but contemporary technology really provides us with better options. And we ophthalmologists are trying to help those patients to adapt to the normal atmosphere and to have visual, perceptual, and also cosmetic comfort. With this, I would like to thank very much for the kind invitation to participate in this exciting forum. And I hope that in the near future, we are really going to have more and more solutions. Thank you very much.